So pigment dispersion syndrome, pigmentary glaucoma. So pigment dispersion syndrome, there is liberation of pigment granules. From where? From iris pigment epithelium, and then what occurs to these granules? They are deposited throughout the anterior segment. Secondary pigmentary glaucoma. So secondary pigmentary glaucoma is common in this syndrome. Pigment dispersion syndrome and glaucoma, pigmentary glaucoma, they are more common in male, particularly young myopic white men. In Africans, where it is rare, the condition tends to affect older hypermetropic women. So in Africa, there is the opposite occurs. In the rest of the world, it occurs in young myopes and whites men. In Africa, it occurs the hypermetropic women. About 15% of patients with pigment dispersion syndrome will develop elevated IOP. So 15% elevation of IOP or glaucoma after 15 years. So 15 years and 15%. Autosomal dominance inheritance with incomplete penetrance seems to be present in at least some families, and a range of genetic loci have been linked. Myopia is a risk factor for clinical manifestation. Higher degrees of myopia being associated with earlier and more severe glaucoma. So myopia, keep in mind, myopia is a risk factor. Secondary pigment dispersion can occur as a consequence of trauma, intraocular tumor, and rubbing of a malpositioned IOL on the iris pigment epithelium. Pathogenesis in primary pigment dispersion syndrome and pigmentary glaucoma. So in primary, there is pigment shedding. Pigment shedding, it is precipitated by rubbing of the posterior pigment layer of the iris against the zonules as a result of excessive posterior bowing of the mid-peripheral portion of the iris. Mid-peripheral portion of the iris. Here you can see deep interior chamber and posterior bowing of the peripheral iris. This posterior bowing causes rubbing of the iris against the zonules. So it will cause pigment shedding. It is believed that increase in anterior chamber pressure relative to the posterior chamber pressure, it occurs due to reverse pupillary block. Reverse pupillary block, supported by the observation that peripheral iridotomy flattens the iris. Here you can see peripheral iridotomy flattens the iris and decrease iridozonular contact. So in this picture you can see flattening of the peripheral iris following laser iridotomy. So the pigment epithelium itself may be abnormally susceptible to shedding in affected individuals. Pigment shedding decreases from middle age onwards due to physiological changes resulting in decreased iridozonular contact. Iridozonular contact. So there is decreased iridozonular contact with aging. Acute IOP elevation. Acute IOP elevation can occur due to direct trabecular obstruction by released melanin granules. Chronic elevation appears to be caused by pigmentary obstruction of the intertrabecular spaces and damage to the trabeculum secondary to denudation, secondary to collapse and sclerosis. Patients with pigmentary glaucoma have increased incidence of steroid responsiveness. Diagnosis: first of all, presentation. Pigment dispersion syndrome and pigmentary glaucoma are typically detected as a routine eye examination. The myopic individuals who tend to develop the condition are likely to be under regular optometric review. Occasionally, symptoms from glaucomatous visual loss lead to attendance, or from corneal edema due to an acute IOP rise following the release of pigment granules, particularly after physical exercise. Signs of pigment dispersion syndrome are usually bilateral but may be subtle and go undetected. On the cornea, pigment is deposited on the endothelium in a vertical spindle shape called Crocomberg spindle. The spindle is not always present, tends to become less obvious in long-standing cases, and it is not pathognomonic for only pigment dispersion syndrome. In the anterior chamber, the AC is deep and melanin granules may be seen in the aqueous. On the iris, characteristic radial spoke-like trans illumination defects are seen in lighter but often not in dark irides. To best demonstrate these, the room should be minimally illuminated and a short, narrow but intense slit beam directed through the pupil. Visualization may be aided by asking the patient to look up. Melanin granules may be present on the surface of the iris, usually inferiorly, which becomes less obvious with age. So melanin granules, as you can see in these pictures, there may be partial loss of the pupillary ruff. Next is gonioscopy. In these patients, the angle is wide open and there is often a characteristic mid-peripheral iris concavity where the iris bows backward. The trabecular meshwork is heavily pigmented in all four quadrants with a dense, homogeneous circumferential posterior meshwork band. So posterior meshwork band. Here you can see in this picture, pigment may also be seen on or anterior to the Schwalbe line. Pigmentation of the angle typically reduces with increasing age. This is known as Sempoulesi line. Next is lens examination. Pigment granules may be deposited on the interior surface. There may be a line called sky stripe or Zentmeyer ring. This is a ring of pigment on the peripheral or equatorial surface around the zonular insertions. Here you can see. What about the IOP? This may be volatile. Some patients exhibit higher levels and wider fluctuations of IOP than in primary open-angle glaucoma. Over time, the control of IOP may become easier as pigment liberation decreases, and occasionally the IOP may revert to normal. NTG can be erroneously diagnosed if the IOP has normalized spontaneously and a PDS signs resolved. So our patient has signs of optic nerve damage and he has normal IOP, so we can suspect normal tension glaucoma, but actually this is uh, but actually it is a pigment dispersion syndrome. Actually the signs are resolved. Posterior segment peripheral retinal pigmentation is there. It may be seen in latest degeneration, is more common than in myopic patients without PDS or PG. The incidence of retinal detachment may also be higher. Glaucomatous optic neuropathy is dependent on disease stage and extent and may be markedly asymmetrical. It is common to find an advanced disease in one eye and relatively mild disease in the other eye. What about the treatment? The individuals with PDS should be reviewed annually to exclude the development of raised IOP and or glaucomatous damage. If glaucomatous atrophy is present, the patient should be monitored at 4 to 6 monthly intervals, as the combination of myopia and PDS can result in rapid deterioration of visual function, so myopic patients should be regularly examined. Lifestyle measures. Excessive exercise can be associated with increased iris pigment dispersion with acute symptoms in some cases. So if the history confirms this, appropriate advice should be given to alter exercise behavior. Medical treatment is similar to that of primary open-angle glaucoma. Myotics are theoretically of benefit because they decrease iridozunular contact, so myotics, and also in addition to facilitating aqueous outflow, but are poorly tolerated by young patients. This medication has the disadvantage of exacerbating myopia. So myotics cause myopia and also carries a risk of precipitating retinal detachment in short-sighted eyes. Topical thymosine. It is a selective alpha-adrenergic antagonist. Induces meiosis without causing spasm of accommodation, but is also poorly tolerated as it causes irritation. So topical thymosine. So laser trabeculoplasty is often effective. It is important not to over-treat eyes with heavily pigmented angles with laser trabeculoplasty. To reduce the risk of an IOP spike, use the lowest laser setting and treat only 2 quadrants. Laser iridotomy has been proposed to retard pigment liberation by reversing iris concavity and eliminating iridozunular contact. It can reduce the risk of intermittent IOP spikes, especially in patients under the age of 40 years, but does not reduce the risk of developing glaucoma. Filtration surgery is indicated more commonly than in primary open-angle glaucoma. The use of adjunctive antimetabolites improves surgical outcome, particularly in younger patients in whom there is a risk of failure. So antimetabolites improve surgical outcome. Post-surgical hypotony and suprachoroidal hemorrhage are more common in young patients with myopia. Thank you so much. So one short topic: acute bilateral iris pigment loss with raised IOP. There is bilateral acute depigmentation of the iris and bilateral acute iris trans illumination. Depigmentation and iris trans illumination. They are distinct idiopathic clinical syndromes, and there is pigment dispersion from the iris into the anterior chamber, and they are more common in young to middle-aged women, and they occur spontaneously or follow a flu-like illness, and they may occur after moxifloxacin or antibiotic, and the primary treatment and the primary process is inflammation, but there is also evidence of phototoxicity following sensitization in predisposed individuals. There is acute bilateral ocular redness and photophobia, and associated with IOP rise, and this is more severe and resistance in depigmentation of the iris. Findings in the two differ, and the pigment is lost from the iris stroma in the depigmentation type, and the iris pigment epithelium, and pigment is lost from the iris pigment epithelium in the transillumination type, and there is marked iris transillumination defects, and there is irregular mydriasis in the second type, in the transillumination type, and there may be different points on a common disease, and differential diagnosis is from the viral anterior uveitis and pigment dispersion syndrome